Welcome to the deep dive. Today we're getting into a really critical topic, a huge shift in how we think about end-of-life care. We're moving away from that, spiralized, very hospital-focused model of palliative care.
Right.
And towards something much broader, public health palliative care.
Right.
Or PHPC.
This might be the single most important area of service redesign happening right now, especially if you're thinking about sustainability, about comprehensive care.
And we've pulled together sources that really lay out the evidence, showing that the most critical parts of care, things like support, dignity, they happen almost entirely outside the clinic.
Far outside the clinic walls.
So our mission today is pretty simple. We want to give you a full summary of the principles, the models, and the data behind this idea of sort of merging professional expertise with community strength.
Because without it, we can't cope. The demographic shift alone is too big.
Let's start right there then. The urgency. You call it a demographic tsunami.
It is. Especially in high-income countries. If you just look at the data from England, it's pretty startling.
Okay.
So get this. 68.2% of all deaths are people aged 75 or older.
Wow. Okay. Over 2/3.
And it gets even more specific. Almost 40%, 39.8%, are 85 or older.
And that's the group that's growing the fastest, right?
Yeah, it's set to double in the next 2 decades.
So 4 out of every 10 deaths are in an age bracket that's about to double in size. You can see immediately how relying on, a few specialist teams just falls apart.
It's mathematically unsustainable. The system just becomes brittle. And estimates suggest that somewhere between 69 and 82% of everyone who dies could benefit from some kind of palliative care.
So it has to be more than just complex symptom management at the very end.
Exactly. It can't stay a specialist referral service for the last few weeks of the most complex cases.
And on top of that, the illnesses themselves are changing. It's not just the predictable cancer journey anymore.
Not at all. The whole trajectory is shifting. It's moving toward chronic diseases and, crucially, dementia. In some parts of England, 1 in every 4 deaths has dementia as a contributing factor. And that means, years of frailty, a gradual loss of capacity, a long, long road needing support.
Which brings us to the big thing the purely biomedical model struggles with, the social cost of dying.
Right. Things like poverty, isolation, and just profound loneliness.
And the loneliness piece is a real public health crisis in itself.
It absolutely is. Just think about this number. Almost 60% of people over 85 who live in their own homes in England, they live alone.
60%, wow.
And when you add frailty or cognitive decline to that isolation, that becomes the main driver of suffering. It can be even worse than the clinical symptoms.
So that's why we have to move the focus out of the clinic.
That's the only way.
Okay, so let's unpack that. If dying is, as the sources say, social, not just physical, how does that change the definition of palliative care? I know this has been a point of tension.
A huge point of tension. The original WHO definition from 1990 was very narrow. It was all about specialist, late-stage, mostly cancer care.
Right.
Then in 2002, they revised it. They reframed palliative care as an approach you could apply much earlier in any serious illness.
And that caused some pushback.
Oh, yes. The sources call it significant disquiet. A lot of specialists felt it was diluting the specialty, that it was watering down the expertise.
Is that a fair concern? Don't you need that high-level specialist for, say, really intractable pain or nausea?
That's a great point, and it's essential. Of course you do. PHPC doesn't get rid of the specialists. It contextualizes them.
How so?
It's built on the social model of health, which says, yes, a specialist is vital for pain relief, but the overall characterizing feature of dying is social.
And that recognition means we need to completely rethink where the money and resources go.
Completely. There's this incredible paradox the sources highlight.
Which
direct healthcare services, so doctors and hospitals, are only responsible for maybe 15 to 43% of all health outcomes. Less than half.
But they get the lion's share of the funding.
Exactly. So if things like housing, social support, and just basic health literacy are what really determine well-being at the end of life, we have to pivot our investment toward that social context.
So palliative care stops being a single service and becomes this whole system with different layers.
Right, a system with 4 essential pillars that all have to work together in what the sources call a seamless union.
And what are those 4 pillars?
First, you still have specialist palliative care for the most complex needs. That's non-negotiable.
Okay.
Second is generalist palliative care. This is the end-of-life care that every GP, every geriatrician, every general nurse should be providing.
So the front line.
The front line. Third, and this is maybe the most important, is community care. That's the family, friends, neighbors, faith groups, the informal backbone where the day-to-day journey actually happens.
And a fourth.
Civic end-of-life care. This is the big picture stuff, the policy, the systemic action. It's often called compassionate cities.
That's the part that feels like the biggest leap. How do you actually, strengthen those informal community networks in practice?
You start with tools. There's a model called the circles of care. It's basically a way to map out the support system.
So you put the person at the center.
Right. The person with the illness is in the middle. Then you have their inner network, closest family and friends. Then an outer network. Then the broader community, and then finally policy and services on the outside.
And the goal is to see who's there, but also who's missing.
And, crucially, to understand the quality of those relationships. It's not just about who can pick up groceries.
It's about, as the sources say, love, laughter, and friendship. How does a doctor even begin to chart that?
That is the core challenge. Professionals often mistake a willingness to do tasks for a deep emotional bond. And when you're mapping networks for, say, homeless people or prisoners, you have to look for who provides that emotional support, not just who completes a task.
If you don't, you burn everyone out.
You burn everyone out, the formal and the informal caregivers.
And this leads us to those bigger frameworks, compassionate communities and cities.
A compassionate community is basically a public health strategy. It's about using community development to build up that local capacity for support so people rely less on formal services.
And the compassionate city is the policy version of that.
Exactly. It's a framework, like a charter, that gets every part of a city involved. Businesses, schools, libraries, local government. They all share the responsibility for supporting people through aging, dying, and grief.
Give me a practical example. What does a business do?
They could implement compassionate bereavement leave policies or train their managers in basic death literacy so they know how to talk to an employee who's a caregiver.
And a school.
They could build grief and loss education into the curriculum, offer support groups for students. It moves this whole experience from being a health problem to a shared civic responsibility.
And we have hard evidence that this works. The Frome Project in the UK is the big case study here.
It's the landmark, yes. And what was so interesting is that it wasn't run by specialists. It was embedded in primary care.
And the intervention wasn't medication.
It was social prescribing. They had these community development workers called health connectors. They would identify vulnerable people and link them up with local, non-clinical support.
So they were social network enhancers.
Precisely. They were tackling the loneliness, the housing issues, the social determinants. And the result over 3 years was it was dramatic.
And this is the part with the incredible statistic.
The Frome area saw a 14% reduction in unplanned emergency department admissions.
A reduction.
While the rest of the region saw a 28.5% increase.
That's massive. That's hard, quantifiable proof that investing in social connection saves money and improves outcomes.
It's not just a nice idea. It's effective prevention.
Okay, let's switch gears to the methodology. PHPC uses the 3 classic public health ideas: prevention, early intervention, and harm reduction. How does prevention work here?
For prevention, it's all about raising the public's death literacy.
Death literacy.
Yeah, teaching people practical skills and just raising awareness before a crisis hits, normalizing the conversation.
And there's a practical tool for this, the LEND model.
Right. LEND is an acronym that gives a simple framework for community action. It's listen, empathy, notice, and do.
So, a real-world example.
A neighbor sees an elderly woman's lights are out when they're usually on. That's notice. Instead of calling an ambulance, they knock on the door. Listen. They find out she's just feeling a bit down and hasn't been out, so they offer to pick up some milk. Do. That's empathy.
And that tiny action can prevent a crisis that would have ended up in the emergency room.
That's the whole idea.
And what about harm reduction? In palliative care, that usually means symptom control.
It's much broader in PHPC. It's about social justice. It means promoting dignity, autonomy, non-judgment. It's crucial for working with structurally vulnerable people, the homeless, people with addictions.
So you're meeting them where they are and honoring their choices about their life and death, even if those choices aren't what we as clinicians would advise. It's about equity.
And the scientific justification for all of this, for prioritizing the social side, it's overwhelming.
It really is. I mean, look at the work by Holt Lundstad. Their studies found that having adequate social relationships gives you a 50% greater likelihood of survival.
50%.
50, that's an impact comparable to quitting smoking.
Wow. And the flip side is just as powerful.
The flip side is loneliness increases your likelihood of death by 26%. Social isolation, 29%. Living alone, 32%. So social connection isn't a soft skill. It's a primarily clinical intervention.
Let's talk about the economic argument for a second. It's rooted in the cost of informal care.
Yes. If you look at the total cost of end-of-life care, family and friends, informal caregivers account for a third to a half of all of it.
Which is an incredible burden.
A huge burden. So the argument is that spending more on formal services, like those health connectors, is justified because it reduces the stress on the informal caregivers.
You're investing in the sustainability of your most important resource.
Which is people.
This all demands a pretty radical change from medical professionals, though. They have to stop being the sole expert.
That's the absolute core of it. The professional has to move from being an expert who dictates care to an enabler and a partner who connects people to social capital.
What are some concrete things a professional could actually do tomorrow to start integrating this?
Okay, so concrete actions. You could embed a community development worker right into your clinical team. You could set up a 24-hour video advice line for caregivers at home.
No.
Or you could start doing after-death audits to see if you actually did a good job connecting the person and their family to community support. It's about creating an ecology where formal and informal care actually collaborate.
Not just run in parallel.
Not in their separate silos, no.
This whole idea, this collaborative ecology, it really feels like the only viable future. Merging the clinical expertise with the sort of latent power of communities.
It is. There's a great summary of the philosophy. The old hospice model told the patient, you matter because you are you.
Right.
The PHPC model adds, and we matter to each other because we are all in this together.
And the pandemic really drove that home, didn't it?
It really did. It showed us that when the formal systems are strained to the breaking point, that psychosocial community support is all that's left.
It's a profound message and a really clear path forward.
Yeah.
So to help you solidify all this, let's wrap up with a quick exercise.
Okay. So imagine you're managing a patient. They have complex symptoms, so they need that specialist palliative care.
All right.
But they also live alone and are very isolated, one of those key social determinants.
A very common scenario.
Very. So based on the 4-part PHPC model, I want you to outline 3 specific actions you could take that are not prescribing a medication.
And for each action,
I identify which partner, generalist, PC, community care, or civic care you would need to collaborate with to make it happen. This really tests if you can put the new ecology into practice.
a great challenge. We encourage you to start mapping those connections today.